Welcome to this case study where we're going to take a look at how at Back to Roots we would build a evidence-based person-centered rehabilitation program for someone with persistent low back pain. We're going to be having a look at the approach that we take to be able to implement exercise prescription using a constraints-based non-linear pedagogy. We'll be using drawn on resources that we use to help support the behavior change to help people get to the things that they're telling us that are important in their life. So this video here is not going to play with any audio on this webinar. It's a 7-minute overview of our workshop with a really dynamic group of exercise physiologists, physios, osteos, chiros in Australia last year with the Knowledge Exchange. If anyone wants to be able to see that, I'm going to play that without sound for 7 minutes now, but that's a nice little overview of a lot of the games and things that I am going to show some of the constraint-based games that we use in this webinar, but we've got a little bit of a narrative overview over the top of that, which helps give perspective of our reasoning behind what we're trying to do. So before we get into the case, I am going to play this video, which doesn't have sound for the purposes of this webinar, but we are going to watch this and see how we apply this, or how we have a go about using this concept of clay. Joel was a willing participant for me to demonstrate this game on. He is clay, and he is enabling me to be able to play with clay. So if any of you have ever played with clay, it lets us mold and sculpt it into different shapes, and when we leave it there, it stays there. And one of the really important cues that I try to give someone who's working with this is, when I am trying to move the clay, is to not give me any resistance, which you can see in certain points here. I'm just checking if Joel is able to be soft and not give me resistance, and let me see if I can shift tension through the various body parts. And as you can see here, I'm getting weight into his hand and then just checking his head for tension. And now this little weight shift here is going to demand him to start producing a lot more force in his front leg and forward arm there. And this approach, or this game, is much more about improvisation and being able to navigate and actually work with a little bit of chaos. So I don't have a script here. I'm learning a lot about Joel's body. I've not worked with him before. I'm able to get, if first and foremost I can get him to be able to dissociate body parts, I can get into his pelvis and see what his range of movement is. I can get into his hips, I can see what his range of movement is, see what his ability to be able to shift tension into the various body parts, and learn a lot about Joel in this very short period of time, about the body parts that he doesn't like moving so much through. Not connecting this at this point to any clinical relevance apart from the concept of clay. This is a concept I took from training with people in circus, because it's very important when you're on balance, when you're on balancing apparatus and you're high up and you're on different bodies, that you're able to shift tension simultaneously at the same time within one body. Being able to be soft, being able to be tense is one of the hallmarks of beautiful movement. And that's what that game really develops. And it's limited only by our creativity, how and where we go with that. We can do it on all fours, we can do it standing, We could do that hanging from a bar, and tension on, tension off. Lots of options within coaching and clinical rehabilitation with that game, as we'll talk about towards the end of this case review, where we can see where I applied this on a gentleman with persistent back pain. The next task we're going to do, so I'm going to have a few demonstrations of tasks as we go through, and then tie it to the case at the end, is something called movement archery. And this, again, I've taken from training with people in martial arts. Capoeira is one of the main influences with this question and answer game, where we make a constraint, and a constraint means that, okay, in these two that we can see here, their feet can't move, but then everything else is able to move. And we use the image of, okay, so this might be an arrow, my arm's going to go straight, I'm going to show clear intention, and you're going to move and get out of the way, and I can throw that in different places. Maybe that could become a lightsaber, maybe it could become a stick, maybe we can use the leg, and then we can start releasing the constraints so that we can actually get to the floor. You go, I go, maybe just I go, maybe just you go, and we can start to try and see what movement options people have to various questions. You can see that we can get people down to squat positions here. We can get people exploring novel ways to bend and twist, having a little bit of fun, a bit of interaction with the person. We can try and drive these movements to specific body parts. So in this example here, feet can't move, shoulders also can't move. So maybe we put a pen or something on the shoulders here, and then we do the lightsaber concept across the torso. If we were trying to give someone the opportunity to explore thoracic movement, an area of the body where a lot of people, particularly when they come to us with aches and pains, will be quite restricted in movement, and they don't have a hobby like dancing or martial arts that will be regularly getting them to explore these movements. So this is a really nice task that we use to be able to play with that. Not telling someone how to move, but giving them an opportunity, creating some boundaries, and then seeing what things that they come up with within that. Applying the same concept here, as you can see in all fours. If we wanted to bring a upper body shoulder component to the same task, clinical reason as to where and when you would use this is not going to be discussed at the moment, because that would always be relevant based on a case, but we'll see how I used it as we move through this case. And it was one of the more challenging ones that I had when I first started my practice here in Mid Wales, and it was a 68-year-old male who was a retired colonel in the military. So he was very high up in the military pathway of authority, and he had 40 years history of low back pain with and without leg pain. And he had come to me for help with his low back pain. So I want to be able to share and take through all the concepts of a contemporary evidence-based practice that I put into this case to get him back to doing the things that he wanted to do. And how we structure rehabilitation, this was something that we learned and covered with Ben Cormack in our early days when we started up, and it's a really nice framework to be able to use these R's, because the first step is always going to be ruling out red flags. If we are a primary healthcare provider, like we are as a chiropractor, an osteopath, physiotherapist in private practice, medical doctors, we are in a position to be able to diagnose, which means that we can perform this red flag triage, or if we're not, we can send to the appropriate personnel for imaging and to get things like red flags that include fracture, cancer, infection ruled out. That enables us to go on to the next step, which is to reassure someone that it's probably not serious. And by not serious doesn't mean any less debilitating, it just means that it's not serious, sinister pathology. Really important, because we don't want to underplay anyone's pain. It has an individual meaning to every person. That is what one of our biggest goals is, to find out what that is, because then we want to be able to reconceptualize pain as an alarm. A lot of our intuitive understanding of pain is that it is a tissue damageometer, and that makes sense because when we're young, we fall over, we cut ourselves, we hurt ourselves, we concede, we get a graze, it bleeds, it hurts. We develop a very close relationship with tissue damage and pain. And the overwhelming literature, some of it which we will be needing to share with our patients to be able to shift away and separate this or cross this chasm from a tissue-based explanation for pain to an alarm system that can be set off by multiple things, and that it's potentially oversensitive, is a really important part of the reconceptualization process. And we're going to need to have a framework to be able to unravel some of the things that we need to be able to reconceptualize. That enables us to get to the point where we can recalibrate and grade the exposure to find out where someone's got to go, where do they want to be, what's a successful outcome for them, so we can look at what those movements are and start grading the exposure to movements, load management, expectation violation, to be able to get the person to those things. Ultimately making them more resilient, building up their capacity to be able to have a greater resilience on a psychological level and on a social and physical level. How that looks as a clinical model, there's lots of evolutions on this since 2016, but it's still very similar. The approaches are still very similar. The patient comes to us and we have screening tools that enables us to triage for the serious sinister pathology. That means that we might recommend that they go to their general practitioner or for imaging to be able to ensure that anything serious is detected and appropriately managed. In the vast majority of the cases of back pain, the answer to this is going to be no, which takes us to the next level of screening, which is going to be some form of psychosocial risk factors, which is not without its flaws because it tries to create a model that we are either low, medium or high risk for a good outcome or for a bad outcome. And the subgrouping in of itself is not how humans work, although it's how most models fit into this. What this process means that if we're low risk, generally we can almost just get on with what we're doing and things will just generally get better. If we're high risk, then there's some more deeper levels of psychology, like anxiety, depression, clinical specialty probably going to be needed in these people. The start back tool is something that is quite often used. It's what we use, and it's what we use in university teaching. There are other stratification systems that are based on doing a similar thing, because what that enables us to then do is move across to identifying a primary pain mechanism. And again, models are nice for flow in schematics like this, but what will always happen is there'll be some carry across between the different ones. So we've got the nociceptive pain, which most of us are familiar with in terms of tissue damage. What this will look like is typically a history of damage to the body tissue that is in the last 6 to 8 weeks. Pain will often follow natural tissue healing times, bleeding, inflammation, scarring, remodeling based on the tissue that is injured, and the pain is related to the tissue damage. So if in the example of an ankle sprain or the potential damage, so almost burnt my hand, but you had that nociceptive little tissue damageometers that are receptive to mechanical, inflammatory and thermal threat or potential threat, and that's why almost burning our hand will give us pain. Didn't damage it, but it set off the little damage detectors in there to tell us to avoid that thermal threat. The pain will most often be local to that tissue, and it will often have diagnostic signs such as your classic inflammation, heat, bruising, that we'll be familiar with injury. People will most often describe this as sharp, aching, or throbbing. And the next one that we would be looking at would be the peripheral neuropathic, and that would be the one that we would actually want to rule out first, because especially with low back pain, that is in the 5 to 10% of presentations where we have a history or lesion of disease to the nervous system itself. So the nervous system is acting as this alarm going all around our body, including our brain at the top processing it. And this would be a damage to that system in of itself. So whereas the nociception is going to be in all of our tissues, sampling the world around us for threat or potential threat, this is an injury or damage to the system that's carrying that information back into our central nervous system and out again, which is why radiculopathies in the neck and the low back, they are maladaptive from the start, because the amount of tissue damage is to the alarm system itself, which means that that crippling leg pain that we'll get with a radiculopathy is disproportionate to the amount of tissue damage. So it's maladaptive from the start, and that would impact how we try and give education and support around the alarm system as a metaphor, even in neuropathic pain. But indications from your physical exam here will reveal some anomaly of the nervous system. We'll generally be able to do our reflexes, and things will potentially have some relation to a medical or systemic cause, stroke, herpes, diabetes, and pain will follow. Not always, but it will be quite logical, even though it's different within people, of, for example, L5, S1, C6, C5, and people will describe that as burning, shooting, or pricking. Okay, so that is going to be our peripheral neuropathic pain. We've got our nociceptive tissue-based pain, and then we have central, which is where we've moved more into the central nervous system. So these changes are going to be happening in the dorsal root ganglion, all the way up in through the spinal cord into the cortices in the brain. And in these instances, we generally have no history of a lesion or an injury. This pain, this just come out of, can't really remember when it started, but it's been with me for a long time. There's no indications from our diagnostic exam, so we can do all our orthopedic tests, all our pain provocation tests, and these don't seem to marry up either. There's generally red flags have been ruled out, and there's no medical cause for the pain that's been established, and pain is often neuroanatomically illogical. It is weird and wonderful, and that's very frustrating when it doesn't make sense. And if we try and apply a biomedical explanation for these strange presentations that are going and moving around the body, some days they're worse, some days they're better, it doesn't make any sense. But when we look at it from a neurophysiological perspective, and we can explain and understand how central or nociplastic changes occur, we can have areas of the body where we have hyperalgesia, so heightened pain that is even off the body. This will still, this will be very confusing until we can look at plausible mechanisms. We often can't say definitively what they are, but we can discuss plausible ones, and these will often be described as vague and dull. And the importance of this is that if someone's coming to us with back pain, is if we have a history of an injury in the last 6 to 8 weeks, and our reasoning is that this is nociceptive, it's going to look very different. The exercise prescription that we're going to be putting someone through, you know, we need to rest and let these tissues calm down and heal, and the pain is going to come back in, versus a central mechanism. And attach this to this case, and the vast majority of what people come to us with persistent aches and pains is that this is going way beyond tissue healing times, and that is going to throw into question that we're waiting for something to be able to calm down to get things going. And these are often the case where we need clinical reasoning and support to be able to get going as quickly as we can. And that will dictate then how we split our approach to practice, being the nociceptive one. They're generally load management. That's just typically your sports injuries, and we take something out initially and then we gradually bring it back in over time, returning all the way up to for high and fast stretch shortening cycle, unpredictable load. And that's often straightforward, and people will generally get better and respond to that. If we have a big component of possibly central mechanisms, then we need to have a look at more, including the top-down modulation of the nervous system, and that is going to have some component of cognitive rehabilitation that has to happen simultaneously. And that's what we're going to be presenting, how we work in a top-down and bottom-up way. The way that Back to Roots works is probably the most similar thing is cognitive functional therapy by Peter Sullivan's group, and it's not an either or. We have to have both at the same time. So if we move on to the red flag triage, there is no red flag as a question, as a test that's going to tell us that this person has a fracture or an infection. We have a sliding scale of, or an index of suspicion. So what this link here, which I can, I recommend is you check out, it's the red flag one on our website. I have a series of questions from this Green Halogen Selfie resource to be able to build an index of suspicion for the likelihood that someone's got a red flag for the cause of their pain. And it's important to build and keep that index of suspicion, asking the questions about night pain, about bowel and bladder, about have you had a history of cancer, because on average, I think that people will see 6, 7, 8 healthcare professionals before a red flag will even be picked up. And that includes medical doctors who are the best suited for and dealing with red flag triage. So it's important, and I have that article open with me when I'm asking someone a question in the history to be able to make sure that I'm covering all the important questions, and that means that I can review that then further down the line should things not change. The next part of our approach is the history, and it's a comprehensive history that we go about not limiting ourselves with any time, because we get so much rich information for triage in there. This is where we get most of the information about our diagnosis that then our objective examination then is just trying to prove or disprove. And it gives us time to listen. It gives us time for someone to be able to tell their story, and everybody feels better when they are heard. And it seldom happens that people are able to actually apply time in clinical practice for all the reasons that time is money, and we've got to be able to get enough people through the door. And we know that the more that students or healthcare professionals are put under key performance indicators, i.e. you need to have X amount of people through the door because that's how a business model works, the more we see unethical practice. And that's a dilemma that we have to sort of navigate ourselves. In the university, we have between 30 minutes and an hour, which is a real time, a real opportunity for students to have a little bit more time to be able to get this interaction. And that's therapeutic alliance. There's a really important part of the potential exercise and guiding someone through those exercises further down the line. I have at least a couple hours for every new patient. And I don't put any time constraints. And if it was going to take longer than that, I would put them back in to be able to make sure we get all of that information. Because that is also leading us into where the first part of what we need to do for reconceptualizing. That's a third R in the 5 R's that we looked at the start. And that's where we have a chance to ask guided questions and then shut up. Then just get that information back without passing any judgment, without passing any challenge, to try and make it in a conversational format. I will have my history set in and my clinical practice. I try and make a coffee shop type environment. I try and dress that there is a person interaction rather than a authority and a receiver. And this is where we use the ABCDEFW mnemonic of Louis Gifford, where we ask key questions to get back potential maladaptive beliefs that could be a barrier to the rehabilitation process that someone is going to be going through. And these questions I have open on this link here, which is yellow flags, and how we get those potential indicators of a bad outcome to then choose which ones we can and can't influence. So the first question, what do you think is causing your pain? And we simply ask it. And that gives us the person the opportunity to be able to tell us what their understanding is, where they're at, what makes sense to them, what they've been told as the cause of their pain. And the sort of information that we could get here would be that they're fear avoidant, that they're catastrophizing, that they have very maladaptive beliefs around the things that they're saying. They're coming back to us, very biomedical understanding of their pain. They have passive attitudes towards their own self-management, and their expectations of activity or work are poor. And we know that those things, expectations, has a really, really high predictive value for people who will have back pain in 12 months' time, as opposed to anything structural like core strength, leg length, posture, muscle firing patterns, all of these things. Expectations, we will get into how we discuss this with our folks a little bit later on, but we want to hear what people's understanding is, and we just write those down and we get it back. The next key question is, what are you doing to relieve your pain? And in asking this, we can get information around if someone's using extended rest, if they are reducing activity levels unnecessarily. Remember, not everybody needs to increase it. Generally, athletes are going to be coming to us, they are more on the repetitive strain or overuse or overtraining spectrum often, and those guys need a little bit less. People come in generally with aches and pains, general population, probably need a little bit more or a little bit different. Other information that we get is that they would be drawing from their activities of daily living and social activities. Their sleep is poor. They are being very no pain, no gain, boom or bust. And maybe there's some self-medication things that we're going to be seeing, like, you know, alcohol. When I drink, it makes me feel better, but then we're into a vicious cycle of that probably is not going to make us feel better in the long term. Compensation, difficult thing to talk about, but it is relevant. We'll talk about it a little bit later around, in an example, whiplash, where that might be a key driver for why someone might have a maladaptive incentive for persisting pain. But is this pain putting you in any financial difficulties? We simply need to be able to ask it, because it could be the barrier as to why they can't even have rehabilitation with us. And if we don't know about it, we can't do anything about it. But when in asking that question, what we will have and what we will gain is a potential lack of incentive to return to work. So someone's being paid for being ill. It's a vicious cycle there, because they're not going to break out of this illness behavior. Dispute of eligibility for benefits or delay in income assistance, a history of previous claims, history of previous time off work. We can get all of this information. Maybe we can't do much about it, but we need to know, because it's going to be a potential barrier to successful outcome. Diagnosis and treatment, really important one, because generally people with persistent pain, they're going to have seen a lot of healthcare professionals. They're going to have tried lots of things. I know if I have pain, I'm going to do ultimately whatever it takes to get rid of it. I don't really care if it's evidence-based, just want it to work. So we need to ask, have you seen someone before? And do you feel that anything was missed? And this is a really important thing that influences the assessments directly after the history. So if someone's telling me that they have, you know, they've got back pain and they're concerned that they've still got a herniated disc because they've had an uncle who had back pain as well, and they eventually had a real disabling low sciatica because of a herniated disc, and they're still unsure as to whether they've got a herniated disc that's causing their pain. And that I need to know, because when I'm going to then do the things in the assessment, the physical examination, if I'm doing the reflexes, I want to be able to be talking through and explaining what I might expect to find if these reflexes were compromised or if they were pathological, to be able to give the reassurance that actually, hang on, these reflexes are exactly how I would expect them to be in a healthy nerve root. If I'm doing a straight leg raise, being able to reassure, the physical examination becomes reassuring in and of itself. Other information that we get here is healthcare professionals sanctioning disability. They've had that, they've been told from another healthcare professional, you need to be off work, you need to rest. Diagnostic language leading to catastrophization and fear. The amount of people who've been shown a really scary image and it hasn't been normalized can be very disabling, and we'll get onto that again later. Expectation of a fix. You're coming to me and you want me to fix your back. Everything that this is about is shifting away from the person becoming in charge of fixing their back and using us as a resource and a guide to really navigate these things for themselves. Emotions. Is there anything worrying you about your pain? Now we're starting to be able to get into what someone's really concerned about, and that's going to be a big reason why they're here, because that could be fear. It could be that we get from that they're actually depressed. It could be that they have anxiety, social anxiety. not feeling valued or worth, and that's where some of the deeper meanings of pain start to really come to the fore. And these things often will not come until you've built up therapeutic alliance. It's not going to happen in a session or two, because someone has to feel safe to open up about these things, particularly guys, in my experience. Work. How is your ability to work affected by your pain? The information that we get from this is that we have a history of manual work, so a lot of labor that maybe someone is not conditioned for. Job satisfaction, someone hates their job every single day, but they believe that work or sitting down is harmful, or working and bending down is harmful. And these things are all going to tie into potentially maladaptive things that could be barriers to the rehab process that we're taking someone through. How does your family react to your pain? Tells us if we've got an over-solicitor partner who does a lot of things for a person rather than giving them the opportunity to be grading exposure and doing things themselves. And maybe someone doesn't have anyone who's got any support, giving them the support. So information there, but the article is also on the website. I have that in front of me, and these are going to be important things that we need to try and guide and get from the history and be able to receive, write it down, and then we decide retrospectively or further down the line, or even there in the moment, if we feel like we're able to have a two-way conversation, but being able to get someone to be able to afford them the chance to challenge those things themselves. We'll talk about why that is potentially a good idea as opposed to us imposing it on somebody, because that does not get us any closer to actual behavior change. So little breakout is going to be going into the next task that I will share on this webinar, which is going to be with a chap called John, again, who's happy for this to be shared, but it's not actually John moving, it's going to be John performing the task on me. And that's an important point I want to put across here. A lot of the things that we're doing with constraint-based movement, and the goal of all of this is breaking tension down as opposed to building tension up, is thoughtless, fearless, relaxed movement. And it can be a little bit daunting for people to open up and to be able to relax and be able to go with the flow with these things. So I will get people to do it on me first, and I will share John doing it on me, and I will leave it to your imagination as to how it then went with me doing it on John to guide breaking down aches and pains. But this task, we use a metaphor of he has a body part, his finger, which is magnetic, and whichever part of my body he touches then becomes magnetically attracted to his finger, so that if he touches me here, I'm going to move towards it, and I'm not going to move my whole body. I'm going to move that body part with as much accuracy as I can. I can't move any more here now, so then I am going to have to find movement from another body part. Or he touches me here, and I'm going to try and move at the shoulder. Touches me here, and I'm going to move at the arm. And trying to find and get really local with exploring this concept of magnets in movement dissociation is, again, a bit of fun, and you'll see we have a bit of a laugh as we work through this here. But it's also, again, a task-based approach to not giving him the answer, guiding him in a methodology of problem solving. All the while, we can get very local here. So you can see that he gets to see when he's touching me in different parts of my body, I'm trying to move with as much accuracy in my spine as I can. If we're playing with the head, we can maybe do with the jaw, the shoulder blade. This task enables us to really get into and explore movement dissociation. That maybe you're already able to see how this is building therapeutic alliance. It's a little bit of fun, but also could connect to a low back pain rehabilitation program, because this is one that we use a lot. When using this, we can use it initially just to be able to have as a little bit of a warm up as a game. But if we've got our healthcare professional head on, we're looking at this and we're saying, right, I've done my assessment, maybe I've ruled out nociceptive pain driver. So we've got other mechanisms that are giving someone a painful experience when they lift their shoulder, when they bend forward, and creative novel ways to explore giving someone an experience in that position. So you can see John now is starting to bring me into a bit of a flexed body posture. But of course, that's not what I'm thinking about. I'm thinking about the task of magnets and moving my body nice and segmentally based on what he's asking me to do. The magnets could equally, we could say that they repel. So every point he touches me, I have to move away until he stops. And so on. Magnets, really fun. The magnet could be on your toe. Nice fun balance game to be able to connect toes with body parts. Limited by your imagination again. This one is breaking posture, and it's another really nice way to try and unravel global tension strategies. So the constraints I put here would be, this was on our course in Australia. Clara is an exercise physiologist, and trying to get this relaxation into her body so that I could put an impulse in any direction. She doesn't give me any resistance, and then she comes back like a nice floppy spring back to start position. And she was carrying a bit of tension there. Watch that again. So as I pulled her back, she wasn't able to distribute the tension. A little bit further. So as she wasn't able to be soft enough, so she had to step back. And I did it again, and she very quickly learned and adapted to be able to receive the input and then to be able to come back, a little bit like a tree in the wind. And this can be going in all directions, and it's about trying to just get that floppiness in the body that a relaxed body might have. Breaking posture, and that can lead into taking all the way to the floor, or just really working on one body part. So let's bring it back to this case with this colonel. When I asked him those A, B, C, D, E, F, W questions, these are the things from the history that came back with him. And so A, what makes sense to you that is the cause of your pain? And these are the things that came back from him. He was certain that pain was due to a trapped nerve and arthritis. He's 68 years old. He was convinced that bending was harmful, and he'd avoided it for years. After he said that to me, I asked him to pick up something from the floor, show me how he does that, because obviously I said, you obviously need to be able to pick things up from the floor. It was part of his goals. So I asked him to show me, if he's not bending his back, how are you doing it? And I asked him to pick up a pencil, and he's 68. He's kept himself physically fit and strong through his years in the military. He showed me the most bolt upright way to bend down to pick this pen up, almost like a full sissy squat. You know, it was a demonstration ultimately that he really wanted to get across that bending was a problem for him. And I had seen him come in, take his shoes off and do full bending. So he was able to bend, but that's not the point. The point was how deeply ingrained his belief and understanding that bending was a problem and the cause of his back pain. And I need to know that, because if his goals are that he wants to be able to, in this case, it was gardening, it was being able to do DIY or decking and things that were down on the floor, he needed to be able to bend down. So this belief is something that is going to need to be unraveled at some point when the opportunity comes in any successful exercise prescription to get him there. He'd also picked up an understanding somewhere along the line that his pelvis was anterior, probably from a healthcare professional that he'd seen. B, what are you doing to relieve your pain? He is resting, and when it's painful, which is most of the time, stop walking the dog as that's too painful, and he'd stop flexing his spine, as I just described there. So lots of the maladaptive coping strategies coming out already by the time we've got to B. D, he had seen an orthopedic surgeon 30 years prior, who showed him an MRI of his back, because he had back pain back then, and was reported to him that his disc was punctured. And this point goes to say how important the words we say are. It's a little bit like having those spinal models with the big red bulge coming out. Once we've seen these things, we can't unsee them. Once we've been told that our disc is punctured, we can't unhear that. It's like toothpaste coming out. Once it's out, you can't put it back in. So the words and the language that we use are probably so much more important than the exercises and the tests and the things that we do, because this one thing that the orthopedic surgeon said to this gentleman had stuck with him for 30 years and was probably the single biggest reason why he perceived that he couldn't bend down. I've got to now be a healthcare professional. I'm a chiropractor. I was 26 at the time. This chap was 68. All these levels of complexity. Right? Why is he going to believe me as opposed to this orthopedic surgeon? Authority. He's a colonel. He loves authority. It's part of his identity. Lots of levels that are going to need to be unravelled if I'm going to be able to get this important message across. And we'll see how I drew on some data and research to support and try and take it away from being my opinion or from the consultant's opinion, for him to make his own, to be able to then challenge it. Okay, and the emotions there, when I asked him, is there anything that you're worried about? He was very defensive over any emotional or psychological aspect to his pain. Again, part of his identity and who he was. And irrespective of whether we want or we're open to be able to engage with these things, it is a leap to be able to be connecting when my back hurts here, that my emotions, my expectations, my social status, my sleep, how these things are connected to the back pain, which I'm feeling right here. It is a leap, and it's our job to be able to help people cross that chasm, because when we can use resources that show how our physiology is tangibly impacted by our emotions, stress physiology, expectations, to be able to impact the way that we can then develop sore and sensitive deconditioned tissues, how we can develop muscular tensions, because it's a protective strategy that are then going to, well, may have been adapted from the start, but they've maintained that, and it's probably a factor in the perpetual pain experience that they're having. So being able to support people across this chasm is a really important goal in these back pain cases, where, as we said, we looked at the primary pain driver, tissues healing, tissues have probably had time to heal. There's probably top-down modulation that is a factor that we need to be able to support. So this is one step towards that. And what we are ultimately trying to do is take these yellow flags being those predictors of a poor outcome that Gordon Waddell, the Scottish surgeon, come up with, because he was a surgeon and he didn't want people having failed surgery attached to his name and his outcomes. So he wanted to be able to develop a way to screen for all these maladaptive beliefs, to find out other ways that and identify other ways that these people need to be managed, because he didn't want to have those failed surgeries attached to his name. The same as I wouldn't want failed rehabilitation attached to my name, and you wouldn't either. And being able to look at these maladaptive strategies and challenge them. What Louis Gifford then come up with is the concept of that, turning that into a pink flag, so an indicator of a better outcome. So if in the instance of someone having, like this gentleman, having passive coping strategies as his main way of managing and approaching relieving his pain, that has been shown with all the research to be not as good as an active approach at getting someone to self-management and being able to do the things that are important to them. So if we can address that maladaptive passive coping strategy to be able to support them to problem solving and looking for active solutions to their issue, then we are giving them the best chance of a better outcome. So of the things that I asked the Colonel here, if I could address or support him to challenge those in the course of this rehabilitation program, he's more likely to get to do the things that he wants to do. There may be some resistance along the way, but this is something that we are working on, turning yellow flags into pink flags. And that's all building on then when we're doing our reassurance, which can start in the examination. As I said, if I'm going to be doing a reflex or I'm doing a nerve root test and it's negative, I can be really reassuring during the examination of this nerve root is actually quite healthy. I don't think that we need to be looking or exploring neuropathic pain as a diagnosis here. And less than 1% is going to be your serious pathology, fracture, cancer, infection. Maybe we've got to triage and get appropriate imaging for those. 5 to 10% is neuropathic. So that's the one we have a job to be able to identify those logical pain referral mechanisms and neurology that will come along with that. But once we've done that, that leaves us with 95% of back pain. That is not serious pathology. It's not neuropathic. So why then is it treated so seriously if we are then working with a non-specific, complex, multifaceted phenomenon that is going to be an individual experience for that person? And that starts to frame the journey or the expectations of shifting towards a process that is going to be underpinned by play, as we would frame it, or giving someone a positive experience with movement. And that is really important. I have a presentation that I did at the ECU here where I was talking about this research shifting towards a biopsychosocial approach and play being arguably the most human or the most evidence-based form of rehabilitation, because it helps us work towards being able to find things that people enjoy, and that is where our biggest avenues for working with people in pain probably lies. And this has to be in continuity, not only in the exercises that we're going to be doing, but the way that we're delivering information. I don't think framing it as education is even necessarily helpful, because it implies that someone is uneducated, but as the information that is supportive of our rehabilitation needs to have a continuity. And that's where a mismatch between very serious and very cold information and then trying to get into playful exercise prescription doesn't work either. So, and on the biggest levels of our institutes and companies in the world, we know that this is how people process information. Playful cartoon animations is an enormous avenue for knowledge translation. Just look at the pandemic that we're dealing with right now, and if you're watching the news each day, they put in behavior changing animations showing how the virus is moving in this way that we can process and follow on the screen, because it helps us to be able to make sense of things. So making things cartoon, making things playful is not playing things down. It's just being able to translate things in a way that we know we as humans process things and we learn better. So we use pain neuroscience education to be able to have as one resource facilitating getting this otherwise complex information across. But of course, we can't just give someone pain neuroscience education. That's not been shown to be superior to anything else either. Behavior change, supporting someone through and actually getting them to self-manage, this is a vehicle, and that's what we use, and it has continuity with the exercise prescription to try and make things fun. San Angel's research on exercise adherence, the global problem, no one's doing it well, no one is, and when I say no one, I mean chiropractic, physiotherapy, medicine, no one is tackling this global physical inactivity, and the number one driver of sticking with an exercise is joy and passion. Did they enjoy it? And that's where we have an opportunity as healthcare professionals to expose people to things that they enjoy, to be able to continue with it beyond it being called rehabilitation. Shifting pain to this metaphor of an alarm is a really important process, because it leads us to be able to explore the multifaceted nature of different things that can set off the alarm. There's an entire target concept in pain neuroscience education that ultimately gets us to be able to use metaphors like our car becoming oversensitized, and those old cars in the 80s where they would go off in the wind and it would be representative of an alarm system that's sensitized, not that there's someone not fundamentally breaking into the car. What's the alarm system designed for? Threat. Bring us back to the nociception and the different pain mechanisms, threat or potential threat. Okay, and that is what we want to be able to shift towards. Why is someone's nervous system protecting them or overprotecting them? This is a game that we're going to, I've got a video of me actually working with the kernel with this one. It's one that I use for delivering some playful variable movement and dynamic bending and twisting. And I've got a video of that to be able to share a bit later on. But again, all of this is about helping someone to cross the tissue injury and pain chasm, which for the vast majority, as we looked at, 95% of back pain is not tissue-based. We're not dealing with nociception. There may be an element of it involved, and especially when we look at peripheral limbs like tendinopathy, there seems to be a clear loading strategy that needs to be applied to that tendon. But then all of these other factors are still equally relevant in calming the nervous system down, because even in tendons, when we can change the symptoms of a person's experience of pain without actually changing the structure of the tendon, which does take several years to often happen. So it's really, really important. The goal of the clinical intervention for a lot of the time is changing the processing of that body part, changing someone's beliefs of that body part, and changing someone's experience of that body part to desensitize to it. And our reference point is not going to be core is firing in this particular way and that we're bending down in this perfect model that we see in lifting textbooks. It's going to be how probably all of us entered the room today. We didn't think about it, we weren't fearing it, and we were just in our rhythm, coming in thoughtless, fearless, relaxed movement. And just the games that we've watched so far, hopefully you can start to connect some dots around how when thoughtless, fearless, relaxed movement is our yardstick for end play, return to work, then those games start to make much more sense than a core exercise program, which can help, but probably not for the reasons that we traditionally thought they did 10, 20 years ago. Top down during bottom up. We can't just give someone exercise and hope that's going to help. The external validity of exercise is not great, and it has to be part of the package. It's active, so it has that. It hits a lot of the boxes of supporting someone to be able to be in charge of things themselves, and it has to be top down at the same time. We can't just give people a pamphlet. We can't just send people videos and give them pain sites. We can't just give people pain neuroscience education. That doesn't work either. It has to be top down during bottom up. How much of each depends on each person, and we have to be able to develop the ability, or that's the art of rehabilitation, for being able to take someone through a process that we would call sensitive to robust. Something that we initially got from Ben Cormack, but we built upon that to be able to label our programs as sensitive to robust. And it's a sliding scale. And what robust is, resilience, could be psychological, could be physical, could be tissue-based, it could be all of those things. It's going to be different based on our needs analysis as to what it is that this person needs to get back to doing. Just needs to get back to gardening, or needs to get back to playing hockey. Going to be different as to how far rehabilitation goes. So how did I go about trying to afford this gentleman to challenge some of his maladaptive beliefs? In about session 2 or 3, when I built up a bit of a relationship with him, we talked about I appreciated that at the time was 26, he was 68, and he had a fear of bending, and he said that his spine was degenerative, he had a punctured disc. So I knew that I needed to find something that he could relate to that wasn't me. So these are, I found some research of the people in Costa Rica, blue zones, where there's some controversy around the accuracy of that, but people who live, and generally the farmers, and they're out in the fields working until very long ages. And for him to see these people bending down and him to be able to connect, because these are actually older than him, enabled him to start challenging the fact that his age was a reason that he couldn't do the things he wanted to do again. It's also where we can draw on data and research to be able to look at normative findings, to be able to show that, his anterior pelvic tilt was something that he thought was a cause of his pain. And when we can look at data and research to be able to say that actually, when we look at men, 85% of people are going to have an anterior pelvic tilt. You're much more likely to be unusual if you don't have an anterior pelvic tilt. In my personal situation, I have an extreme anterior pelvic tilt, which means that my lordosis of my low back is actually a problem when it comes to certain training and things. I do have to really work against it. But this is a really effective way of having pain literature and resources to be able to show people and give them the chance to challenge things for themselves. He had a punctured disc, so being able to show him research on if we have a herniated disc and then we scan it and we can see that, and then if we scan you again 3 months later, it's probably 50% smaller. And if we scan it again in 9 months, it's probably completely gone. And another disc is going to be bulging, and whether it's symptomatic or not is going to be probably dependent on whether it's near a nerve root, etc. But this process is going on all the while, and 40% of people with no back pain are going to have bulging discs if we just scan them. Being able to show the research around this is really, really helpful. And this goes beyond just back pain, and these concepts are going to be relevant for any presentation of persistent pain that comes to us, because some people are going to be looking and saying, okay, this all sounds great, but I've got a rotator cuff tear. That must be relevant. And that helps us to be able to then apply this same concept to be able to say that 1 in 3 people over the age of 30 have findings on their scans of pathology in the rotator cuff. And if we go above the age of 70, 2 in 3 people will have abnormal findings in the rotator cuff. So again, at his age, if he didn't have findings of a rotator cuff tear, it would be unusual. Even after successful surgery for rotator cuff issues, more than 2 out of 3 people have abnormal findings on their scans and in their rotator cuff. Using this pain neuroscience education, we can look at data around low backs. So most people will treat backs differently and say that they've had back surgery, and they'll be told, it'll be reinforced that they can't get back to doing the things that are important to them or the sports. And that is so often not the case. We've got data of 80% of NFL players who undergo back surgery and get back to playing NFL, 85% in NBA players. And it's really important for people to have this information, to be able to challenge that and to be able to engage in a graded exposure to slowly build over time to get them to be doing these things. The knees. 1 in 3 college players with no knee pain show significant issues on their scans. Just on a personal level, it was only a couple of years ago that I developed knee pain in my left knee, and I even started to get some clicking and catching, all the hallmarks that I would be looking for of a meniscus injury in someone who came to me. And even knowing all of these things, we're not immune to it. I went and got an MRI scan in which I was able to get a diagnosis of a degenerate lateral meniscus that is almost completely gone. We chose not to do surgery, and I slowly built up over time, and I'm back doing all the things that I train pretty hard and do lots of deep knee flexion and rotation, twisting, plyometric things. And I wouldn't have any idea that I have no lateral meniscus, but for the fact that I scanned it and imaged it, and I know it, because I know that hasn't grown back. So that's, again, leads us down the route of over-imaging being a problem. When we scan and we look inside, we're going to see scary things that, unless they're normalized, will be potentially debilitating, like being told that we've got a punctured disc. So really, really important to be able to undo that. Only 50% of people with arthritis of their knees experience pain. Some people have ACL tears that don't even know. This gentleman, age was a factor, and he needed to be able to, I wanted to be able to challenge the concept that it was, not disregarding the fact that he's 68 years of age, but being able to look at degeneration as a reason for he can't bend down, having data and this bell curve, so the age along the bottom, up to the age of 70, this goes, and then degeneration in this green line that is going to be going increasingly up the longer that we live. So I'm 31 now, I'm going to have X amount of degeneration in my knees. I've scanned it, so I've seen I've got no lateral meniscus, and at 41, I'm going to have more degeneration. At 51, at 61, if I live to 100, it's going to be even more wrinkles on the inside as my hair turns grey. But when we look at back pain, we get this bell curve that increases around the 20s and comes down in our 60s, and it doesn't have this 1 versus 1 relationship with, I'm getting older, I'm getting more degeneration. It is a nociceptive driver of pain. And this helps be able to give someone reason to explore, okay, so what else? So if degeneration isn't explaining this big increase in back pain that we see in this time between 25 and 65, what else is happening in that time? And often that can help us get down and into the things that are happening around that time. We're having families, we're on the career ladder, we're doing sports, we're doing all of these things that probably at some point we have hit some inability to balance that allostatic load that is probably much more worth pursuing in terms of back pain rehabilitation than thing that is out of our control, which is degeneration of the spine. And some people will have a similar argument around neck pain and whiplash. So some people will have one car accident and experience whiplash that gives neck pain that persists for months and even years, and being able to then go into looking at, okay, say normal people who have a normal, it's normal for them to be having car crashes. So derby drivers, where they will have 50 crashes per event, 30 events per year, and every crash is 25 miles per hour plus. Only about 2% of demolition derby drivers go on to experience persistent neck pain. So what's different between demolition derby drivers on a tissue explanation-based explanation of the neck pain? One car crash of 25-30 miles per hour going on to cause persistent long-term neck pain versus this accumulative tissue-based. You know, this person's probably doing something that they really enjoy and they're getting a thrill and all of these factors, versus this person who's got a liability and a claim, and all of these factors are going to be entwined into it as to whether someone's probably getting persistent neck pain. But medically trained people who have whiplash on average get back to work 200 times faster. Again, being able to understand these things and reduce the threat, really, really important, because we have a role in getting this information across to people to help them reduce the threat and reduce the persistent pain. Some people will have widespread pain, fibromyalgia, and being able to show that it is possible for people who have widespread pain, when they embrace it, when they engage it and they accept it and they can move with it, they can still see people who are very successful with fibromyalgia running as CEOs of major companies, still competing in ultra endurance events. People like Morgan Freeman turn it into a real strength and write about it, they're embracing it and engaging it to be able to turn it into an opportunity to inspire other people. And that's a really, really good example. As healthcare professionals, we have aches and pains just as much as the people who are coming to see us. What's the difference? Again, we understand it, the threat's less, we can engage with it, and it's our role to be able to get that across to people. So in this example, the last thing that we want people to be able to take from it is that we're in any way insinuating the pain is in their head, but we want to be able to get across that the experience is very, you know, we appreciate the fact that we're experiencing pain, and that's not disputable. But in this instance, this chap's had 25, 30, 40 years of pain. We've probably been able to pass through the tissue healing times, and there's other mechanisms that are going to be at play to be able to explain the pain. So while we can hopefully get across that this anterior pelvic tilt, this bending, degeneration, we probably don't have a tissue issue, we have a pain issue. And this is all about supporting him to then get to the point where we can explore what are the things that he can take control of to be able to engage with a pain issue. And at the end of those sessions, there's little cards which show that people who understand more about pain can engage with it. It's why healthcare professionals probably can get back to work faster. It enables us to be able to turn the threat, make it smaller, and be able to move on. And what I will get people to do is take pictures of these cards, and then they send it back to me as an email so that I can then have a gauge of how I will do the next session. It tells me what they've heard, doesn't tell me what I've said, it tells me what they've heard, which is much more important than what I've said, because if they're hearing that, okay, this all sounds good, but the pain is, he's saying that the pain is in my head, then I haven't got my message across, and it forms the basis of the next session. So that's an example of how we would try and challenge maybe one target concept using something someone can relate to and some hard data. This gentleman then asked me a really interesting question, which was, do I have to believe in this process for it to work? Which again is a little bit along the lines of, are you suggesting that this pain is in my head? And while I encourage and I will support every person who comes to see, I want to be encouraging you to be a critical thinker, I want you to be asking questions. Being cynical is probably not in this gentleman's interest. And the reason for that, for me to be able to explain, is that we have an internal drug cabinet in the brain. We have endorphin system that we can tap into, and we have power to be able to do that. We know when we go running, when we get an aerobic exercise hit, we get the runner's high. And that experience most of us can be able to connect with is stimulation of these chemicals in the brain that then can flush down the danger messages that are coming in. Remember, we've reconceptualizing pain as an output, not an input, and we've got nociception that's going on the whole time. If we've got a threat like a tissue-based injury, there's going to be more nociception coming in as a danger message. And when we have aerobic exercise, we can stimulate this internal drug cabinet to be able to flush down and stop our central nervous system receiving more nociception and receiving more potential for threat. You know, when we are playing sport, things hurt more when we're losing than when we're winning. The same amount of tissue damage, we are able to modulate top down by the context. If I'm winning, it doesn't hurt as much. And that's all, again, the same basis of descending modulation that expectation is based on. Positive expectation, the other word for it is placebo. Negative expectation, the word for it is nocebo. And we don't, it's not a this is or isn't or something in between. We've got one or the other. And there's really clear research that shows that you could take a proven analgesic medication, give it to somebody in a drip, but tell them they're not receiving it, and it doesn't have any impact on their pain. The nocebo, the negative expectation, cutting out these descending modulators, can undo a physiologically plausible mechanism. So if you are given a curse, so I'm going to say to you that you have 7 years of bad luck, you then go around looking for bad things to happen. Guess what you see? Bad things. Again, vision is an output of the brain. So being able to have and facilitate a positive expectation, again, remember, expectation is connected to whether someone's more likely to have back pain in 12 months or not. We can talk and show about that research, because it's not like saying, right, just become a positive person, but it is maybe our job to be able to say, well, this is a tangible impact. Our thoughts and emotions have a tangible impact on our physiology and processing of pain. And if we have a positive expectation of the process, then we have more chance of having a positive experience with the movement. And that is an honest discussion around placebo and nocebo. Top down, during, bottom up. It's not either, it's not or. And when we can then get into the discussion around a healthy nervous system achieving the same task in multiple ways, it again leads us towards exercise rehabilitation that's going to facilitate that, getting outside this linear, very easy to prescribe, but A plus B then C approach to restoring healthy movement variability. And they should be based on the end goals that the person is telling us about, rather than it being based on a single leg squat or based on how long someone can hold on a Sorenson's test. What's important to the person, we get that in history. And in this gentleman's case, it was gardening, walking, DIY, and getting back to rowing. And of course, rowing involves flexion, which he had put as a limitation on himself, because he wasn't going to row, even though he'd enjoyed it in his younger days. So this, when we're looking at the needs analysis of the things that we want to start doing with our exercises, we look at gardening, we look at walking, we look at bending the DIY, and we say, right, that task looks like it needs to be bent down and needs to be able to move in these ways and awkward positions and with a certain amount of load to pick things up, and that's going to help us pick things that we're going to put into our program that helps us support him to build a buffer for movement capacity and tolerance based on the things that he needs to be able to do. Expand his envelope of function, build his ability to self-manage on his own, self-efficacy probably going to be the biggest driver of someone sticking with something, and help him avoid things like boom and bust and fear avoidance approaches, which is a challenge when you're working with someone in pain. We're saying exercise and movement is important, and how do you go about doing that when it hurts? Especially how do you go about doing it when it hurts and you're away from me? Well, we need to build up an implicit understanding that hurt doesn't equal harm. Getting across the chasm of a biomedical explanation for pain to a biopsychosocial one, to sore but safe, and that means we have a license to touch it, tease it, and nudge it to start building over time. So let's have a little look at some of the things that we had and did with the Colonel. This was a novel way of just trying to support him to experience bending down. He was actually pretty fit, but just putting him on a little bit of a rope there, that was a bit of a perturbation challenge, got him thinking about that and bending down. This is the stick task. Again, that I said to before, I didn't have a video of me doing it with someone else, but I've got me doing it with him. Any of you watching familiar with the Ida Portal type stuff, this is where we can take something like that and put it into clinical reasoning for supporting bending down in a novel way, in a reactive way, in a fun way, and we change the constraints around how much bending we want him to be able to explore. So we're alternating here, dropping the stick, and can't touch the stick anywhere below the top third. Maybe we've progressed to that, but that means that you can't touch it also till it's at its longest distance, and maybe we say we can't grab it till it's below our knee height. So we have the stick being able to move in different directions, and he's having to remember we're trying to reinstill thoughtless, fearless, relaxed movement in this gentleman's ability to bend down and pick things up. Reconceptualization of the beliefs that led up to this point was far more important than any exercise that I could have done to be able to get him there. But to get him to that point, very, very rewarding. And on the front, with regards to building his capacity, then his resilience to be able to bend down and pick things up from the ground, we use the Jefferson curl, which is an exercise popularized in gymnastics. Legs stay straight, hold something, and then fully flex all the way down and back up, and doing that slowly over time with a progressive load. Maybe you could add a little bit of a twist. How did we pick how much load? Well, a 20 kilo bar was something similar to the things that he said he was lifting at home. He then continued this away from me with the program using a cement bag, which was 20 kilos as well. And again, I like to tie back to, with this particular gentleman, had I built up his tissue tolerance through specific adaptation to impose demand over time, or had I just released his top-down modulations and constraints and supported him to doing something that he could already do? Probably much more the latter in the time frame, because to impact tissue adaptation, we need to be working with something for months. Training programs are only successful that's why training programs are done in microcycles, mesocycles, and building years on years, because that's how we impact tissue tolerance. When we're talking about tendon rehab, really, we can impact tendons by specific loading, but it's 2+ years to do that. Symptoms don't necessarily follow that timeline. We can change that with all these other factors in a much shorter period of time. This task was about building up his, so he was coming from his Jefferson curls, as you can see there, and then I wanted him to be able to pick up, so while the stick task was much more about variable, quick ways to be able to get bent down, a lot of people will say, it's when I was least expecting it, I bent down and I put my back out. That will be what people will say most often. Here, I wanted to roll out different medicine balls, so I got medicine balls in this gym from 2 kilos up to 12, and he was walking backwards, coming forwards, and I'd be rolling a medicine ball out into various positions and getting him to pick it up and throw it back to develop a little bit of power and reactive ability under load, with, again, the goal being that these are things that are movements a little bit like this that he needs to be doing in his daily life, bending, twisting, and picking things up. So what else was in this chap's program? We built a little daily whole body flow after the reported findings of the second session, which was a simple mobility sequence that we agreed that he could do each day. Something similar like just rolling the neck, rolling the shoulders, rolling the elbows, just a little bit of just juicing up the joints to be able to get them moving. Then on all fours, doing some cat-cows in extension and flexion, because I wanted to make him feel safe early on to be able to explore flexion and extension, that we could then make it more playful and explore different ranges as he went. And this was about 10 to 15 minutes that he could make it a little bit longer or shorter each day as he could, and 30 minutes walking per day. We looked at the research that showed that if we compared people who did a core exercise regime 3 days a week compared to People do the same amount of time walking, look at the impact on back pain, and again, we see that the walking or the core program was not superior to walking. So we looked at this, talked about this, and agreed that he would do a certain amount of walking because he said he wanted to be able to walk his dog again. So this become part of his background exercise. And again, we give a narrative around trying to get some of the aerobic runner's high component to get in and stimulating this descending modulation as that component of his program. And as an overview, that's how it looks. Home exercise program was walking and a little flow routine and pain neuroscience education. So that again, I could get back from him via email or via, generally via email. I'll get that. Some people send it to me via social media if that's how we're communicated. But again, I can hear what this person has heard there. I've got an example now in a couple of slides, but so not everybody engages with that, and that's the case. If that's the case, we got to be able to work with it, and some people just need to be able to talk through things. But generally, the people who engage with this are the ones who really will take ownership and are shifting away from me becoming the person who's going to fix them and do all of the legwork. So just that's my personal experience. The people who don't want to engage with the homework, that is a little bit of a resistance to the behavior change, that they're actually the ones that are after that. But that being said, I've had people who we purely just talk about these things, and we've been able to get them to the things that they want to be able to do. Local movement awareness. So we did cat-cow 3D. That was where we first started. So just working for periods of time, exposing to flexion and extension of the back. And we used clay, as we saw at the start, to try and start making him feel safe with me holding him and guiding him and giving some supportive words around it to be able to explore different novel movements, breaking tension down. We also use the arrows and lightsabers games as a little bit of as a method for building up our therapeutic alliance, but again with around all the clinical narrative that we've been talking about through this session, releasing the constraints to making it all the way up to being able to do the sticks, which is about him being able to pick it up and react and turn and move in different directions, strengths off the ground. We also used floppy springs, which is breaking posture, to be able to try and just get rid of these global rigid strategies around based around trying to reduce muscular tensions. And we used the medicine ball pickups for sets and exploring picking up progressive loads variably and throwing them back to develop some power. Jefferson curl was the main thing that we used to build up his, once we were able to bend down, we used the Jefferson curl then to load up bending down and build up his resilience and buffer for lifting. And we agreed to be able to build that up to about 30 kilos that he was going to do 3 times a week. And he continued doing that away from him with cement bags to continue. And, you know, as I argued before, do I think that was at that weight a physiological adaptation, or in terms of a load management adaptation of his back, or a top-down release of his own perception of his body? I think I would probably go with that one. Either way, he got to being able to do bending down, gardening, and the things that he wanted to be able to do. Did he still have pain? Absolutely. And what changed mostly was the meaning of his pain. And all of this looked like 8 one-hour sessions that consisted of pain neuroscience education tailored towards the maladaptive strategies that we wanted to unravel. Some people don't have those, some people have more. We had the home exercise program, playful movement prescription, progressing from sensitive to robust, building up his ability to manage things himself so that he doesn't need me, but also hopefully doesn't need anybody else. How do we pick the dosage of these games? It's a little bit more difficult than the classic 3 times 10 of each exercise, minimum effective dose. So we need to be able to be willing to do trial and error. We need to be able to do a little bit too much, because we don't know where someone's at. But if we go with the approach of minimal effective dose, so with that stick game, I would maybe start off with nice, easy constraints. That means that he can catch it at waist height, and we're going to be keeping it very predictable, and we're just going to go for maybe 3 1-minute sets. And then I'll see how he responds. He can let me know how he responds next session. And then we build from there, because then we have a baseline of what constraints are used and how much we did it. And then we can build from there. Okay, minimal effective dose, something that Ben Cormack talks a lot about. And I like this quote from Mary. She's a great researcher in back pain, part of the Peter Sullivan group, where she talks about people will lift with different techniques that they find comfortable and more efficient for them, just like we do with running or anything else. And being able to practice and explore these are the best way to be able to figure that out. And a coach, trainer, or healthcare professional is going to potentially help. And that's where I think, as healthcare professionals, one of the arguments or the concerns is, what's really separating us from being a personal trainer, because a lot of these things are within the scope of a good personal trainer that is educated, and there's some amazing personal trainers that are really clued up with being able to grade and adapt and individualize exercise programs. But what we have to be able to do, if we're going to be addressing maladaptive coping strategies, is being able to do this at the same time. So even if you're working through and someone's concerned that, oh, bit of back pain, and maybe I put my back out now, we can come back, and as healthcare professionals, we can do the tests again and perform. These reflexes are showing that there's no need for us to change our clinical reasoning for the plan of management. Maybe we just need to appreciate again that we're working on an alarm system, and we set the alarm off. We need to just back off now today, come back at things in a couple of days' time, and we can build. And our ability to be able to marry up the clinical reasoning with the rehabilitation is what a truly evidence-based contemporary healthcare professional is doing. And when we can guide someone through a flare-up, which is where their alarm system goes up, and we can maintain their function through that, that's where we get a real penny drop moment, in my opinion. It's the most difficult time, but we get the penny drop and we get the buy-in after that, because hang on, I have got through this flare-up, and I am still able to engage in my physical activity. We are able to use the toolbox, or what we describe as a toolbox, for applying the education or the information in addressing these important beliefs. Doing movement and exercise is a really important thing to be able to try and get someone to find something that they enjoy. Can we make it fun, play? And these games is a really effective way. If we're talking about relaxation, we're getting some of the lifestyle design stuff, shifting from fight or flight and stress physiology, we can apply pain neuroscience education to help just simply get someone to do things that they either enjoy again or find relaxing. It's going to be different people. Some people, it might be yoga or stretching. Other people might be reading a book or playing music. Being able to help that, being able to pace the things that someone is boom and bust, so they just no pain, no gain, got to get stuff done. Grading exposure to things that someone needs to be able to do. In this case, low back flexion. We need to find a way to get a starting point, and then being able to build in until we can ultimately get there. We can use manual therapy. As chiropractors, we will be generally expected to manipulate, perform spinal manipulation and body work. We've got lots of different adjunctive healthcare options, and that will be dependent on your professional training and probably the expectation of the patient that's in front of you. Setting goals and finding out what those are that are meaningful to the person are going to be really, really important for buy-in as well. A program without goals is one without direction and will lead us to falling off the bandwagon. So some barriers to this approach are going to be individual to you, depending on your constraints, what space you have access to, what equipment. What I'm proposing here and what I'm taking through requires very minimal equipment. I started my approach doing this based on the fact that I had no equipment, so to develop clinical reasoning skills to be able to work with someone not needing much. But we have got constraints now, like practicing in person. A lot of stuff is being done through telehealth, and I actually don't see that delivering a lot of this high value care through telehealth is a problem. I took through some pain neuroscience cards here and was able to talk and communicate and then give exercise prescription. We can still do that through telehealth. So that's an option. Other things that I popped in there is what you're wearing to be interactive. Are you able to sweat through the day? Are you able to move? I can't speak for your particular clinical environment, but yeah, the clothing that you wear may potentially be a barrier. And here I have another little example of a gentleman in his 60s who was working with me, persistent back pain, and similar duration program. And this is an arrows task where he can't move his feet, and my leg is a lightsaber. He's trying to move as little as he can, but as much as he has to, so that he doesn't get touched by me. And of course, I'm in control of where I want to be able to offer the place for him to try and evade. And I'm going to pause that there, because this is the moment that I'm often after, because it's got to be fun. And generally when we have pain, I know when I've had pain and I needed to seek out health care before, or sports injuries, it makes us miserable. The very nature of it stops us doing things we want to do. And it is, not surprising that people with pain have mental health profiles that lend themselves towards being miserable and being down, because that's what it does. So having a healthcare process that we can get a smile out of somebody is probably going to have therapeutic value as well in and of itself, over and above everything else that we've talked about. Here's an example of how homework would come back to me from another lady that I've been working with now, Jackie, for a couple of years, and she has very high buy-in. She finds it really interesting talking about all these things. But this is an example of what a homework card coming back, but so that I want to make sure that she has got self-management strategies for flare-ups away from me. So she's taken a picture of one of the cards, and there's some key questions, for example, at the top here. So write down any questions that you had about today, and I will say, anything that did or didn't make sense, I want to make sure that I can get that across in the next session. So she said that she didn't have any questions, and she's been reflecting on it and thinking about how she still pushes herself that extra little bit, but she's trying to make sure she keeps the peaks and troughs. So that's boom and bust things. She wants to keep those small and keep her exercise and exposure to small increments. It looks easy on paper, but putting it into practice is another challenge. So the next thing that I want to hear is 5 things that she can do to calm her system down when it flares up. And these are what she came back with: to learn more about how pain works, regular exercise, so walking the dogs every morning, changing the processing, so she's working on that with myself and Nick, the trainer here at the gym, relaxation, so for her, she meditates and she does 20 minutes of mindfulness each day, good sleep, reading a little before sleep, but doing some breathing practice as well as alternating palm rotation stretch. She was seeing me for persistent shoulder pain, and plenty of warm-ups before exercises in the gym. I wanted to hear any things that she has hard, crash cycles, approaches to her pain, and how she might break those down. So she said the most obvious task is training. She started on Tuesday. She's looking at alternative ways to change the way that she's pressing, rather than just, my training program says I've got to train, so I'm going to press through. Fear of pain. Have you noticed any tasks or exercises that you are afraid to do? The upper body training and lifting anything heavy has clearly been a concern. Now I understand more about pain and the brain. The fear is definitely diminishing, and I'm beginning to understand what to do to better manage. The final one that I put on there then is pacing and graded exposure. So write down the things that you'd like to be able to do again, so that we can increase and work towards that. And she said, doing this with training, especially around pressing, and thanks to you guys, I can see how changing the process and coming at it differently, I can still work out and build up again gradually. We took some things out, but the goal would be ultimately to get it back in. She's also applying that to other things like gardening, and instead of picking up a heavy pot or a compost bag, I ask my husband to carry. So I'm not stopping doing anything, I just make sure I'm not overdoing it at the same time. And this little line I put in pink at the bottom: looking forward to next Monday, which is, again, a sign, all of this information that I'm getting back from this person. The buy-in is high, and she is going to be, okay away from me, and she ultimately doesn't need us, and she is able to truly self-manage. So the references are there. I hope this has been helpful to see an overview of how we might construct a return to work, return to play exercise rehabilitation program based on persistent low back pain, making rehabilitation evidence-based, person-centered, relevant, and fun.